Hello, everyone, and welcome to our 22nd edition of What's New in Addiction Nursing. My name is Emma Garrett, and I'm the director of the Addiction Nursing Fellowship. And I want to just take a moment to thank you for joining us today in your busy lives. And it's my distinct pleasure to introduce Christine Deziel, who has pulled together a really great presentation on a really important topic. And so Christine is one of our nursing fellows right now. She's an RN and a BSN, and her work is as a clinical resource nurse with the Drug and Alcohol Resource Team at Richmond Hospital. And before that, she worked in direct patient care and leadership roles across the continuum of care in mental health with a focus on crisis intervention. Christine is particularly interested in addressing stigma and access to harm reduction in acute care settings, as well as improving transitions of care for people who use substances. Other interests include managed alcohol programs and injectable OAT, and also smoking cessation interventions. And I share the interest, and I think it's a really important topic. So Christine's presentation is entitled Time to Quit, a review of smoking cessation interventions and their impacts on substance use outcomes in addictions treatment. So we'll hear from Christine over the next period of time, and then there'll be a chance for questions at the end. So turning it over to you, Christine.
Great, thanks Emma for the introduction, and welcome everyone, and thanks for tuning in today. I am respectfully acknowledging that I am a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflicts to declare today. Okay, so before we get into the presentation, I wanted to share a little bit about myself and why I chose this topic. As Emma mentioned, I've worked across the continuum of care in mental health prior to working in addictions care, and I've noticed that many of our clients in this population smoke, and that it's tended not to be the focus of care, as there are often many more pressing health concerns, along with the belief that clients don't want to quit. I also remember the days of visiting clients in an indoor smoking room inside a psychiatric facility, and staff smoking with patients, as well as providing cigarettes as a positive reinforcement or a way to engage clients into care. It's curious to me that in the history of working with this population, we've readily provided cigarettes to clients, and yet we don't offer other legal substances like alcohol or cannabis to clients for the same reasons. I've had the privilege of working more recently at a smoking cessation clinic, which really opened my eyes to the reality that some of our clients do want to quit and they can quit smoking. In my current role in acute care, clients will often say that they are thinking about quitting, but need to focus on their other addictions. And if they are in recovery, they express concern about relapsing if they quit smoking. So I wanted to dig in and find out what the evidence is specific to cessation in this population. And this leads us to the learning objectives for today, which are to appreciate the prevalence of tobacco use and health outcomes in people who use other substances, to understand the historical barriers and facilitators of smoking cessation intervention, to describe the impacts of tobacco cessation interventions on substance use treatment outcomes, and lastly, to describe some treatment approaches and clinical considerations in this population. In Canada, tobacco use has declined over the past 5 decades from approximately 50% in 1965 to 15% in 2017. And yet, it is still the #1 cause of preventable disease and death. We know that smoking is a major risk factor for cancer, heart disease, stroke, and COPD. It kills more than 8 million people worldwide per year. Despite this overall decline, people who smoke and use other substances remain disproportionately affected. 74 to 98% of clients seeking substance use treatment or in recovery use tobacco, and their tobacco use is 2 to 4 times that of the general population. Concurrent treatment of tobacco use disorder and other substance use disorders has been limited due to questions of effectiveness and concern for negative effects on substance use outcomes. So what is unique about smoking in people who use other substances? They're more likely to start smoking at an earlier age, smoke more heavily, and more likely to be nicotine dependent. They are also more likely to die from tobacco-related causes than from their substance use disorders. And smokers that have co-occurring substance use disorders can experience synergistic effects. The concurrent use of alcohol and tobacco can lead to an increased risk of gastrointestinal cancers. Many experience an increase in cravings for other substances as well. Alcohol and tobacco are often used together and can lead to mutual cravings. Smoking may lead to urges to drink, and drinking may lead to urges to smoke. Epstein and colleagues found that tobacco use and cravings were strongly linked with the use of and cravings for cocaine and heroin. I also wanted to mention the economic burden that's placed on people that smoke. Many of our clients are on income assistance and persons with disability benefits and have a very difficult time even affording the basic necessities. And so for our clients that smoke, they often spend the majority of their very limited disposable income on tobacco. So what are some factors that are associated with this large disparity? Some biological links for clients with substance use disorders who smoke are explained by nicotine working on the same neural pathways as other addictive substances, such as alcohol, stimulants, and opioids. The effects of nicotine are as powerful as other substances in the pleasure center of the brain. For some mental health disorders, there are some neurobiological factors that increase the likelihood of smoking, make it harder to quit, and negatively impact the nicotine withdrawal phase. Nicotine may also provide some brief relief from some of the side effects of psychiatric medication. The psychosocial circumstances of substance using clients also plays a role, as tobacco use has been linked with lower income, unemployment, boredom, and isolation. Our clients might reside in supported housing or treatment and recovery settings where smoking is prevalent. Their social circle may also be comprised mostly of other smokers. Clients, like the general population, also use tobacco as a daily routine to cope with stress and anxiety. Some environmental influences associated with this discrepancy also include the impact of the healthcare system. Professionals may believe that clients are not interested in quitting, might feel that it's not their job to deal with smoking cessation, and therefore it's not addressed. They may not feel confident in how to support smoking cessation. And the last factor involves the tobacco industry. They've played a role historically in targeting individuals with mental health and substance use disorders. In the 1980s and early 90s, tobacco companies gave free cigarette samples to homeless shelters and psychiatric hospitals. They also provided branded items such as blankets to homeless people and shelters in New York. Okay, so I'd like to take a minute to offer everyone some time to think about barriers you faced in your practice in addressing smoking cessation with your clients. Okay, so what does the literature have to say about what gets in the way of addressing tobacco use with our clients? Staff attitudes have influenced addressing tobacco use with our clients who use substances. Some common themes in the literature include beliefs that tobacco is a lesser problem than more immediate issues related to other substance use and psychosocial stressors. That smoking is a client's right and choice, and so why would we take that away from them? Staff feeling that quitting is too stressful for clients or too difficult. Beliefs that clients might not be motivated to quit smoking, as well as concerns of worsening agitation or aggression if clients are not able to smoke. Fears that quitting might affect clients' recovery efforts during substance use treatment is another consideration. These beliefs can all lead to staff not discussing tobacco use and the evidence-based treatment options with clients. So, among addictions treatment staff, tobacco use is commonplace. There's been an association between staff use of tobacco and their likelihood of addressing tobacco use with clients. Staff who smoke are less likely to provide tobacco intervention with clients or support a cessation program in their work setting. This may be due to feelings of guilt related to their own tobacco use. Conversely, staff who do not smoke are more likely to offer tobacco intervention to clients and support a cessation program. Another barrier is a history of substance use treatment culture and the normalization of tobacco use. The co-founders of AA both smoked heavily and died from smoking-related causes. I've heard clients mention the ritual of smoking behaviors before and after 12-step meetings and how ingrained this is in the treatment and recovery culture. Stop smoking with clients was discussed as a way to develop rapport and engagement. This sends a message to clients that tobacco is not a real drug and that nicotine addiction is normal and smoking can be seen as a therapeutic event. Traditionally, clients who were entering treatment for substance use disorders were encouraged by staff to not make major life changes aside from treatment for alcohol or drug use, and this includes quitting smoking. Lack of staff education and training around tobacco cessation and treatment options has been another barrier to exploring cessation with clients. Healthcare providers have often received little or no specific education on tobacco dependence. Providing education to staff can enhance knowledge, skill, as well as change attitudes. And lastly, the lack of resources to treat tobacco dependence, especially for pharmacotherapy, is a limitation. In my own and my colleagues' clinical experience, nicotine replacement therapy used to be supplied by treatment programs to be able to offer immediately to clients when they were ready to quit. Funding has since been cut off and NRT is no longer available at some addiction services. In the literature, inpatient service lacked or had limited medication options, and outpatient programs relied on clients to cover the cost of medications themselves or through their extended benefits. So what are the effects of smoking cessation on primary substance use outcomes? When searching the literature, I found one meta-analysis, 2 systematic reviews, and 1 narrative review that examined the question of effectiveness of smoking intervention or cessation and its effect on substance use outcomes. Despite client and staff assumptions that smoking cessation may destabilize or threaten those in recovery or impact their ability to quit other substances, most studies found that quitting smoking does not contribute negatively to substance use outcomes and may improve recovery or reduce use of other substances. Smoking cessation intervention may increase the chance of quitting. I think it's important to note that although clients who use substances may have a lower tobacco quit rate at longer-term follow-up than the rest of the population, smoking cessation intervention can strengthen abstinence for clients over the long term, even if they don't quit smoking for the long term. One outlier is related to the timing of cessation attempts. An older Ann Joseph study found that alcohol users who delayed quitting smoking until 6 months post-treatment had longer periods of alcohol abstinence compared to those who quit smoking and alcohol concurrently. These results are inconsistent with the rest of the literature. I also wanted to note that much of the literature looking into the effects of cessation on substance use treatment was conducted some time ago and was a secondary outcome in a few of the reviews. The quality of the studies included were rated overall as low due to concerns about lack of details around methods, diversity amongst participants, and unclear risk of bias and lack of heterogeneity in some reviews. Here are some common themes that came up across the meta-analysis, systematic reviews, and narrative review and contribute to the main findings. The effects of different types of tobacco cessation interventions were examined and included pharmacological interventions such as NRT, bupropion, and varenicline. Psychosocial treatments included counseling, contingency management, motivational interviewing, brief advice, motivational enhancement therapy, relapse prevention, and cognitive behavioral therapy. Combinations of pharmacological and psychosocial treatments were also included. Study participants were in various stages of change, from just starting to actively in substance use treatment and in recovery. Treatment settings varied and included inpatient residential treatment, outpatient substance use treatment, primary care clinics, a psychiatric hospital, and a psychiatric outpatient clinic. Different substance use outcomes were identified through the studies included, from abstinence to reduced days of use. A variety of types of substance use disorders were represented, from alcohol, stimulant, opioid, and cannabis, as well as polysubstance use disorders. Different study designs were also included. Randomized controlled trials, secondary analysis of randomized controlled trials, cohort studies, and a case review. Despite all these variable factors in the literature, the general findings and conclusions on effects of smoking cessation on substance use outcomes are similar. I'm now going to highlight a few randomized control trials that were included in the previous reviews that focus on some common substances that our clients who smoke may use concurrently. This study by Winhausen and colleagues evaluated the impact of concurrent substance use disorder and tobacco dependence for patients with stimulant use disorder, cocaine and/or crystal methamphetamine type. The setting was in the United States at 12 outpatient substance use treatment programs. The sample was comprised of 267 adults with a diagnosis of stimulant use disorder. And they smoked 7+ cigarettes per day for at least 3 months and were also interested in smoking cessation. The intervention was a randomized 10-week trial of substance use treatment as usual compared with treatment as usual plus smoking cessation treatment. The smoking cessation treatment group received extended release bupropion 300 milligrams plus weekly individual cessation counseling. Contingency management and nicotine inhaler were added later. Follow-ups were conducted at 3 and 6 months post-smoking quit date. Outcome measures, smoking abstinence was measured by carbon monoxide. Weekly stimulant and other non-nicotine substance use was measured by self-report and urinary drug screen. For the results, the study showed that the treatment as usual with the smoking cessation treatment group showed better smoking abstinence rates overall and more drug-free days at 6 months compared with the treatment as usual group. There were no significant treatment effects on stimulant use between the groups. Okay, so next, this study by Shoptaw and colleagues had a look at evaluating the effects of relapse prevention and contingency management for optimizing smoking cessation outcomes using nicotine replacement therapy for smokers on methadone maintenance. And the study was conducted in Los Angeles at 3 outpatient opioid treatment centers. There were 175 adults on methadone maintenance included in the study who smoked 10+ cigarettes per day and were interested in quitting smoking. So the intervention was 12 weeks of treatment with nicotine replacement therapy. There were 4 arms with follow-up visits at 6 and 12 months. The 4 study arms are below. There were nicotine patch plus relapse prevention, nicotine patch plus contingency management, and lastly, nicotine patch plus contingency management and relapse prevention. Smoking abstinence was measured by carbon monoxide reading, and urine drug screens were done 3 times per week, along with self-reported number of cigarettes smoked. What the study showed, there were higher rates of abstinence from smoking found for the 2 contingency management arms during treatment. No similar effects were noted for the relapse prevention group. At follow-up visits, there was no longer any significant effects between the 4 study arms. Participants had more opiate and cocaine-free urines during weeks of smoking abstinence compared with weeks that they used tobacco during the treatment. The last study we'll look at is by Rosenau and colleagues, and they looked to compare the effectiveness of motivational interviewing compared with brief advice in either 1 session or with 2 booster sessions in combination with nicotine replacement for people with alcohol use disorder in substance use treatment. The setting was an inner-city state-funded residential treatment program in the United States. The sample was comprised of 165 adults with a current diagnosis of alcohol use disorder who smoked 10+ cigarettes daily for the past 6 months and were not using any nicotine replacement or bupropion at the time of the study. 73% also had other substance use disorders, stimulant, opioid, or cannabis use disorder. The intervention randomized the sample to either motivational interviewing or brief advice with and without boosters, provided during a 30 to 45-day treatment program with follow-ups at 1, 3, 6, and 12 months. Smoking abstinence was again measured by carbon monoxide and self-report, and drug use was done by self-report and urine drug screen, as well as interviews with family and friends. The results of this study showed that brief advice led to higher levels of motivation to quit compared to motivational interviewing. Tobacco abstinence was equivalent for both groups at follow-up. Clients with more pre-treatment drug use, more than 22 days in the past 6 months, that received brief advice had greater smoking abstinence at 12 months than the motivational interview group and those with less drug use. Booster sessions led to an increase or 16 to 31% less cigarettes per day compared with the MI group. There were no effects from either treatment type or smoking cessation on alcohol or other substance use outcomes. Okay, so what does all of this mean for our practice? We should always offer all clients who smoke and use other substances evidence-based tobacco cessation intervention, regardless of the type of substance use disorder they have, the treatment setting that we see them, or their stage of change. Offering clients tobacco cessation interventions can improve the odds of tobacco cessation, improve physical health, have no impact on or improve client goals related to primary substance use outcomes from both an abstinence and a harm reduction lens. For clients that are not ready to quit, brief advice and motivational interviewing can increase levels of motivation and quit attempts. Okay, so what helps us in addressing tobacco use with our clients who use other substances? Facilitators in the literature suggest that integrative treatment can be supportive. Offering clients smoking cessation at substance use treatment programs where they already attend is recommended. It provides an opportunity to address tobacco use, increases the chances of quitting, and strengthening their other substance use outcomes. I think it's important to note that although it is often assumed by healthcare providers that clients don't want to quit, the research does not support this. Several studies looking at clients with various substance use disorders report that clients are highly motivated to quit at rates that are on par with the general population. Having tobacco cessation programs embedded in addictions treatment programs also improves staff attitudes towards addressing tobacco use. Policy changes can also help. Treatment facilities that have implemented smoke-free premise policies have found that clients are more likely to use tobacco cessation services and to smoke less. Policies to restrict staff smoking with clients was also recommended to set an example. One study found that where reports of client and staff smoking together were high, smoking rates were high. And when reports of co-smoking were lower, clients' attitudes about and intent to quit was higher. And they also received more tobacco cessation intervention. Treatment programs with smoke-free premise policies also had lower rates of staff and clients smoking together. Many healthcare providers are interested in receiving training in smoking cessation treatment. Education and training are crucial as staff attitudes and beliefs affect the uptake of addressing tobacco use in substance use treatment services. As staff who work in this field already have expertise in helping clients with change, they are in a great position to support cessation efforts as well. Providing education about effects of tobacco use and cessation treatment, as well as other motivational enhancement strategies, can help less motivated clients to strengthen their commitment to change in a low pressure manner. I'd like to pause again for everyone to consider any tobacco-related policy changes that have been implemented in your workplace. And how have they impacted your clients and your own practice? The CanAdapt Canadian Smoking Cessation Guidelines for the Specialized Population of Mental Illness and Other Addictions state that healthcare providers should screen all people with mental illness and other addictions for tobacco use. Healthcare providers should offer counseling and pharmacotherapy treatment to people who smoke and have a mental illness or other substance use disorders. Healthcare providers should monitor clients' psychiatric status and/or other substance use disorders when clients are cutting down or quitting smoking. Medication doses should be monitored and adjusted as needed. As healthcare providers, we can start with screening and brief intervention using the 5 A's. Ask about tobacco use and document the client's status. Advise all clients who use tobacco that quitting leads to health benefits. Assess their readiness to change their tobacco use. Assist by offering evidence-based treatment options for clients who are ready to quit. and arrange follow-up or referral to tobacco cessation services. One study recommends adding a 6A, affirm. We want to affirm clients' past successes to enhance their commitment to the quit plan. Some clinical considerations to keep in mind when supporting clients with smoking cessation. Smokers with co-occurring substance use disorders will need oftentimes increased doses of nicotine replacement therapy for longer periods of time compared with the general population. We want to provide information to clients about caffeine levels being reduced by the interaction with tobacco smoke. When quitting, the effects of caffeine will be amplified. We want to assess for and educate clients about the possible need for reduction in other medications affected by tobacco and commonly used by clients with mental health and substance use disorders. And they are antipsychotics, benzodiazepines, antidepressants, opioids, and insulin. It is the tobacco smoke, not the nicotine, that interferes with medications and can potentiate or reduce those effects. And lastly, we want to monitor regularly for any changes in mental health. Quitting smoking can lead to depressed mood and anxiety due to withdrawal effects. Clients with comorbid mental health conditions should be monitored for changes in mental status. I thought it may be helpful to review some local resources that you can offer to your clients. The VGH Smoking Cessation Clinic offers free one-to-one smoking cessation support from physician or nurse trained in tobacco dependence, and clients can self-refer at the number on the screen. And the BC Smoking Cessation Program provides BC residents with a free 3-month supply of nicotine replacement or some prescription smoking cessation drugs once per calendar year. And Quit Now is a free confidential 24-hour tobacco cessation helpline with trained counselors. Clients can call, text, or visit online for more information and support. And there's also an educational resources section online for healthcare providers. Okay, and here are some resources available for healthcare providers. The Ontario Tobacco Research Unit offers this free online course called Tobacco and Public Health from Theory to Practice, which covers tobacco cessation, prevention, protection, evaluation, and e-cigarettes. The TEACH project through the Centre for Addiction and Mental Health in Toronto is another fantastic resource for clinicians looking to enhance their knowledge base in tobacco use intervention. They offer interdisciplinary online courses, many of which are specialized for different populations, such as mental health and addictions, First Nations, Inuit, and Métis, women, and youth. To wrap things up, I'll leave you with this Mark Twain quote and a reminder that tobacco use disorder, like other substance use disorder, is a chronic relapsing brain disease. Clients may have multiple quit attempts along their journey to cessation, and they can benefit from support around this. Healthcare providers already have much knowledge and skill in supporting clients with other addictions and can apply this when addressing tobacco use with their clients that are ready for change. Okay, now we have some time for questions.
Thanks so much, Christine. It'd be great if you could just bask in some applause, but hopefully we can just, take the time to have some questions. So for folks who've joined, there's a few options for asking questions. You can raise your hand and Adrina, our organizer, can unmute you. So that's a nice way of making this a little bit more interactive. If you have the chat function that you can see in that sort of panel on the right-hand side, you can type a question in there, then everyone can see your question. So that would be the optimal way to type something in. And then if you're on a phone, I think the only option is to ask a question in the question box, and then Adrina will forward it to myself and Christine. So yeah, feel free to raise your hand to be unmuted for a question, type into the chat, or alternately into the question box if you don't have the chat function. Yeah, again, Christine, just great summary. I think it's such an important topic, and you really highlight something that, yeah, certainly in practice, I've also found to be a bit neglected, but so important. And obviously, there's lots of evidence that does support offering tobacco cessation interventions to people who use other substances. So I have a question just to start us off. I was curious, so there's obviously like the big sort of pieces of evidence with the reviews and the analyses and the RCTs. I'm just wondering if you found anything more qualitative that sort of had patient perceptions in there, or sort of, yeah, anything that had more patient perceptions around what it was like to quit smoking as someone who uses other substances or is in recovery.
Yeah, thanks. That's a great question, Emma. I didn't see any qualitative reviews per se, but I guess some things that stand out to me when I was reading the literature would be around that clients want to quit, and the rates at which clients, when they interviewed clients, clients were more interested, almost doubly as interested in quitting smoking than providers thought they were. So I found that piece really interesting. And even there were some studies that mentioned around clients going into residential treatment and being offered like kind of brief advice or motivational interviewing types of even information sessions with they had no intent to quit. And some of those clients ended up doing a quit attempt based on these educational sessions that were part of the treatment program. So even for people that aren't looking to quit, there are some strategies that allow them, I think because of the low pressure kind of way it's rolled out, that allows them to maybe change their mind after getting the education and support.
So interesting. That's such a huge gap between provider sort of expectations or assumptions, and yeah, that they're doubly interested in quitting. That's yeah. So it feels a little bit like the onus is on healthcare providers to shift things. I have another question that's kind of related to that while we're seeing what else rolls in, what sort of percolates for other folks. Kind of knowing some of those pieces that people are interested, but that there's a lack of implementation. What do you think it might take to kind of get smoking cessation more integrated in substance use treatment? I mean, you can reflect on your past clinical experiences or your current clinical work, or some of the places you've visited during the fellowship. Yeah, but what do you think it would take to kind of get this more integrated and to sort of shift some of those perceptions of providers?
Yeah, I mean, I think the first thing is education for staff. I mean, even for myself, having worked for a short time at a smoking cessation clinic and doing the teach course that I mentioned as part of the resources, which I thought was a fantastic course that was all done online, so very accessible. I found that just even for myself, getting educated on it and having the opportunity to apply that knowledge in practice was the first step, because once you kind of get the information, it really opens your eyes. And seeing clients quit is another thing that's just I found amazing, and kind of changes your attitude to know that people can do this with the right support. I think one of the places that I visited in this fellowship was Heartwood, and they did an amazing job. They have a smoking cessation group that they run weekly, and clients are expected to attend even if they're not interested in quitting, just for information. And the uptake there, I don't have any stats around that, but there were many clients there that had quit smoking or reduced their cigarettes. So I thought that was a great thing. So I think having ways to engage clients that is really low pressure and low barrier is another great step in the right direction.
That's an awesome suggestion. So there is a question that one of our listeners typed in. So this is from Matthew McGuigan. I hope I said that right. Let me just scroll up. So have you encountered any clients who use e-cigarettes? If so, do you provide NRT support, and how do you assess for their NRT needs? That's a great question.
That is a great question. In my clinical practice, I used to ask people if they smoke, and now I've just included vaping in that as well, or e-cigarette use, because I find we were really missing people. We asked people if they smoke, and they said no, they aren't smoking, but they are still using nicotine. And so they may have withdrawal symptoms that need to be treated in the hospital or managed. So what I've heard from from some physicians that that I've worked with around how to address that is to ask, what exactly did they say? They said to kind of ask people before they switched to e-cigarettes, how many cigarettes per day were they smoking before they transitioned to e-cigarettes? So that can give you an idea, because patients tend to self-titrate with the e-cigarettes to their nicotine levels where they were at when they were smoking. So that's one strategy. And I think the probably official answer is to go with PRN, or as needed nicotine replacement options, like inhaler, gum, or lozenge first, and you'll get an idea how frequently they're using those products. And that may give you an idea whether you need to step it up to a patch, or maybe they're able to manage just with the PRN options.
Great, thanks. That's
Yeah.
super helpful in terms of, yeah, framing it when people might not have the same way of like counting cigarette intake as when they're vaping.
Yeah.
Just, we can see if there's any other questions coming through. If you type a question into the question box, it just takes a moment for it to get forwarded to us. So sorry for any delay there. I had another question too. I guess kind of related to this sort of low pressure cessation support you were talking about. It seems to be almost more of a harm reduction approach in a way. And I guess either sort of through clinical work or in the literature, have you seen much that sort of supports like reductions and affirms reductions that people are able to make? I remember from visiting Heartwood when they had I think it was a contingency management smoking program, and people would blow the CO2 monitor and they would celebrate, you know, like a reduction from the week before in terms of what CO2 level that people were blowing. I'm not sure if you got to go visit that group, or if anything came up around reduction as opposed to full cessation.
Yeah, you're absolutely right. That is what they're continued to do that at Heartwood when I was there a few months ago, except with COVID happening, they're not using the breathalyzer, the carbon monoxide tool anymore. So they are still continuing to do contingency management. And I guess what I know to be true from the literature is that we don't say cutting down can be a very useful strategy on the way to abstinence, I guess, because we don't know what is a safe level of smoking. So that hasn't been really identified. But I think it's a great strategy to, some people just can't think about completely giving up cigarettes. And so giving someone an option and celebrating like small successes, like reduction, can be, I think, a really positive way to engage people and to just kind of increase their, what's the best way to say that? Just to play on their strengths and celebrate the small wins.
There was a question from Lonnie Whitman, who works at BC Women's. She was just asking if you talked about e-cigarettes as a way of cutting down, which wasn't covered in the presentation. So thinking about e-cigarettes as a harm reduction approach. She said she was thinking about the population on First Square, where e-cigs would be definitely better than tobacco in terms of, thinking about perinatal care. So obviously didn't come up and it was like less the focus of your presentation, but just wondering if that's came up at all in your searching, or is something you've encountered anywhere?
Yeah, actually it is something that I think is starting to come up in the literature. There is a new study that looked at e-cigarettes versus nicotine replacement, and showed, and the results out of that were that the e-cigarette group was more likely to be abstinent, like by quite a significant amount at the 1 year mark compared to the nicotine replacement group. And I guess some of the things to consider is that we still don't know the long-term health impacts of e-cigarettes, and so that part's unknown. It is probably better than cigarettes, but we just don't have that information, I think, at this point. So that's where I guess the kind of conundrum lies, is that we don't know, but it was successful in this study. Like at the 12-month mark, most of the people that were using e-cigarettes had not returned to tobacco use, but we're still using the e-cigarette a year later. Yeah.
Right. So yeah, so maybe, thinking about it as a harm reduction approach, but also sharing, when you're doing education with patients, that there isn't a lot still known about long-term outcomes. I
Yeah.
think that evidence is really still rolling in.
Yeah, absolutely.
Here's a question from Amelia Cassidy. The way the questions show up are so tiny for me, so sorry, I just have to scroll. Are there any follow-up studies for folks that leave inpatient treatment and return to community, so back to their homes and usual habits? Yeah, so kind of, I guess, how that might affect smoking habits or smoking cessations if they were able to achieve that.
That's not something that came up in any of my literature search, so I can't speak to that specifically, but that's a really good question.
Yeah, I mean, I
Yeah.
think it's a great question in terms of, even if you think about some of those groups that you talked about, that's that sort of long-term support with perhaps, NA or AA or other groups people might attend where there is this particular culture around it. So maybe if they'd been in a treatment setting and were able to achieve smoking cessation and then kind of back into places where, smoking is really around. I mean, I think it's really like any other substance use disorder, right? Where you need to sort of that ongoing care and support and check-in and management of cravings and triggers. And we know that with many substances, but there's such distinct environmental cues for smokers in terms of, like, I remember I used to talk to people about, like, you gotta, like, maybe even move your furniture around and, like, not not have like that chair in the same spot that you always smoked in while you watch TV, those kinds of things.
Yeah, absolutely. I think one thing that comes to mind about that question now, that in the studies that I did look at, there, a lot of the clients were able to quit smoking initially, but the effects really dropped off for the long term. So at 6 and 12-month follow-up, the rates tended to be quite low of abstinence. So part of the research was mentioning that, like, future research should really focus on, we know that clients can quit in the really short term, but how do we engage these clients for the long haul to help them? And I guess that may be part of your question, is like, when they do go home, what type of supports or interventions will help to clients to maintain that abstinence.
Yeah, and I think that also probably, like, speaks a bit to some part of like a cultural shift that's sort of needed throughout the continuum of services. Lonnie just responded to our sort of discussion around e-cigarettes as harm reduction. Just that we although we don't know the long-term effect of e-cigarettes, we do know the long-term health impact to both moms and babies with actual tobacco. So.
Oh, absolutely. Yeah, specifically in that population, for sure. And I guess the other thing I wanted to mention about that, I'm glad someone brought it up, was that just that if people have failed at all other options or treatments that we do have, is that we shouldn't really discourage people that from e-cigarettes if they've tried absolutely everything else and are kind of more, what we'd say, like, treatment resistant, especially with the risks of harms, particularly like perinatal and that. And so it's always something that you're done with the client, in collaboration with the client, of just explaining what we do know about the risks and benefits.
Yeah, that seems like an important part of the education, and but yeah, perhaps more of an area for harm reduction for tobacco cessation, as opposed to, like, being considered like a treatment, although obviously in some cases can help people work towards cessation if that's their goal.
Yeah.
But lots of people may not have that as their goal yet. So yeah, I'm curious if there's probably no studies on it yet, but with e-cigarettes, if there's anything looking at people using e-cigarettes concurrently with some of the medications that can support, or even with NRT as a way of cutting down.
Yeah, I have not seen anything around that yet.
Yeah.
Yeah.
Just seeing if anything else pops up here. I think it really is quite astounding what some of those stats you presented, that 74 to 98% of people who use other substances have concurrent tobacco use. That's just astounding. It's like not surprising, but when you see that in comparison to other folks, it's or to a population who's not using other substances, it's quite astounding. So I think you really highlight a key area that needs some attention, some ongoing attention, and might be less feel less urgent than an opioid crisis, certainly. Or some of the other more imminent needs that our patients may have, but that in many cases is the most harmful practice or substance that someone may be engaging with and may have desire to quit too. So it sounds like there's lots of work to do to both educate healthcare providers and instill hope in patients who maybe do have that desire to quit, that it's just as possible for them as for anyone else too. I guess as we wrap up, do you have any sort of final thoughts or pearls around what people could kind of take away with them today and take back to their practice?
I guess what stands out for me is just that patients are interested when you take the time to ask about it. And I think that, like I had mentioned earlier, getting some more information or education for yourself on that, because I really feel like it's, and I've heard from other colleagues as well, that they didn't feel very confident in knowing how to address tobacco use with their clients, and that kind of, along with assumptions that maybe they don't want to quit or they're not interested. So I think maybe seeking out some of the resources to get better informed and educated, and just start talking with your clients about their tobacco use. And, if they've tried things in the past, I would say I found it really helpful to dig a little bit more about what didn't work about the last quit attempt. And you can gain a lot of insight that's helpful in making the next quit plan with people. And I find they're quite receptive when you actually engage people around a conversation, if they're ready. And we always leave the door open, right? And I think continue to check in about it, like we do with other substances.
Yeah, and I think there's also, like with other substances, there's been misconceptions related to tobacco use treatment as well, sort of like how much NRT people can be on, sort of like the rap that varenicline or Champix got for a long time, whether you can combine therapies, whether you can smoke while you're on the patch, these types of things. So I think there's lots of work to do demystifying some of that as well, especially with people who've had previous quit attempts. And I also found normalizing that multiple quit attempts is super normal, like not getting it the first time is like way more common than getting it the first time. And that, it's framed differently because people wouldn't typically like go to detox or treatment for tobacco cessation, but it's just as difficult to quit as anything else. And so and that it's normal for people to make multiple quit attempts. That's like more the norm, right? I think like an average of like 7 to 15 quit attempts is what it is before. So great. I think so great to kind of cover this really in depth and highlighting some of the resources, because once you sort of dig, there's so many resources in terms of supporting people. I'm really curious about the application of contingency management, perhaps, like along with some of these other things, maybe to make tobacco cessation a little bit more sort of fun or engaging for patients and providers as well. So for those who aren't familiar with it, contingency management is rewards-based system. So you'd go with usually a biological marker, so people can blow like a CO2 level, and if it was, you set it up in different ways. But if people are able to not smoke, they will not have they will have a CO2 reading below a certain level, and then getting a sort of prize draw for that. So I think kind of some ways of making it fun could maybe also help with implementation too. Cool. Well, thanks so much for that great presentation, and thanks everyone for your attention and your questions. This session has been recorded, so it will be sent out to folks who signed up to attend, and yeah, let us know if you have any follow-up questions as well. So big applause. Awesome work, Christine.
Thanks everybody for tuning in.
Yeah.
Hope it was helpful.
Have a good afternoon.
Okay.